It's really wonderful to be here this afternoon to talk to you a little bit about Parkinson's disease and how it can affect the bladder, and really to talk to you about the ways that we evaluate um, the bladder symptoms in patients with Parkinson's as urologists, and then also the treatments that are available for it. A lot of people think bladder problem with Parkinson's, that it looks the same way for everyone with Parkinson's, but there are different patterns, and with each pattern of symptoms, there's different treatments that are offered for that. So I'll go into a little bit more detail with that. And in the part where I talk a little bit about what causes it, I'll try to make sure that I take my time through that part, because that's part's a little bit complex, of course, but hopefully helpful in understanding why it happens. So in patients with Parkinson's disease, urinary symptoms are very common. So when we talk about urinary symptoms, the most common is an overactive bladder. So what does that mean? That means strong and sudden urges to go to the bathroom that you can't ignore. You've got to drop everything and try to get to the bathroom as quickly as you can. Most patients with Parkinson's disease experience this. And then another about 30%, not only do you get these strong urges to go to the bathroom, you actually lose control of the urine and may have a few drops or a gushing large amount of urine leak out before you make it to the bathroom. The other symptom that many Parkinson's patients experience would be urinary frequency, which is going to the bathroom very frequently. So more than 8 times in a 24-hour period would be considered abnormal, and that's considered urinary frequency. And then nocturia, which means getting up 1 or more times at night to urinate. Now, most Parkinson's patients experience this. A lot of people without Parkinson's also experience this symptom as well, but it is one of the hallmarks of urinary symptoms in patients with Parkinson's, and often is related to, again, the sleep disorders. These usually go hand in hand. Less frequently, we see difficulty emptying the bladder, and sometimes we see that in combination with the other symptoms that I just mentioned. You get the strong urge to urinate, you run to the bathroom or as quickly as you can, you get there as quickly as you can to use the bathroom, and then nothing happens. You kind of sit there a few minutes before the urine starts to finally empty. And often that is related to, again, slowness of the muscles. So the sphincter, which controls the urine and keeps you from having accidents or urinary accidents on yourself, or urine accidents or leaks, is often very slow to open up and allow the urine to come out when the bladder is ready to empty. And so it can be challenging kind of balancing these two things, because they're on two ends of the spectrum, right? We're having a difficulty emptying the bladder, but we're also feeling like we need to go all the time. So symptoms in patients with Parkinson's, as I mentioned at the beginning, can have a very wide range. They can be very mild and they can be very severe. But one thing that they have in common is that they can have a significant impact on a person's quality of life. And again, they're present up to 65% of people living with Parkinson's, and it's more common in women than men. And generally, when you are presenting with Parkinson's disease symptoms, you generally have the other symptoms first: the tremor, the slowness, the rigidity, the stiffness, and then generally the urinary symptoms come after that. So next, I'm going to explain why people with Parkinson's disease experience these symptoms. As physicians and scientists, we really understand that the brain, nerves, and bladder have to really work together in a very complex but delicate system in order to store urine properly and for, long periods of time. So a few hours rather than, feeling like you have to go to the bathroom every hour, every 30 minutes, and then also to empty the bladder efficiently. So I'll start by describing normal bladder reflexes. When we are babies, our bladders function primarily by reflexes. We have little or no control because the brain really isn't involved. So here I have a picture. I have a picture of the brain and the spinal cord here, and then this is supposed to represent the bladder and the sphincter muscle and the urethra where we pee. Okay. So when the bladder is full, it sends a signal to the spinal cord, and this is in a baby, okay, before the brain gets involved. And then the spinal cord sends a signal back that allows the bladder to contract. Bladder contracts, it squeezes, and the sphincter muscle relaxes, and the urine empties, and the bladder empties. In babies, though, the brain isn't involved. So the bladder is constantly sending signals to your spinal cord to say, hey, there's some urine in here. There's some urine in here, but doesn't necessarily only send it when it's full. Your brain decides when it's full, right? The brain kind of decides that. So in a baby, the bladder may not be completely full, and it'll send the signal, and the spinal cord will say, yeah, go ahead and contract, and then you pee and empties. But then the brain matures, right? As we get older, the brain matures and then kind of takes control of things, okay? And we know that there are multiple areas of the brain that are involved in this. It seems very simple, but it is actually very complex. So I like to think of the brain as kind of an air control air traffic controller. So basically it's telling different parts of your body what it should be doing and at what time. And it's controlling the bladder as well. So let's say we're in a scenario where the bladder is not full. So the bladder sends the message to the spinal cord to say, hey, there's some urine in here. And then that signal goes up to the bladder, and the bladder says, nope, it's not a good time to pee. It's not full. Such and such, she's busy. She's dealing with something else right now. Not a good time. So bladder, do not contract, do not empty. And so the bladder relaxes. It doesn't empty, right? And then this allows the bladder time to actually fill up and allows us to get to the bathroom at an appropriate time to pee. Okay, so if the bladder can also be full, but if it's not, let's say that you're out shopping or something like that, you're grocery shopping, it's not a good time to pee. The bladder sends a signal, and the brain is aware that's not a good time and says, hold it, don't squeeze yet. She's not ready to pee yet. And it holds it. Now, when it's an appropriate time to pee, again, bladder's full, the bladder sends that signal. The brain checks with everyone and they say, yeah, it's a good time to pee. Then they turn it on. They turn the system on. And then the signal to the bladder to contract is made. Now, you're sitting on the toilet and you're ready to pee. And then the bladder contracts, the muscle relaxes, and the urine empties. So that's the normal function. That's what should happen. Basically, your bladder is constantly sending signals to your nervous system, your central nervous system, or your brain, your spinal cord, and saying, hey, there's some urine in here. But your bladder is able to differentiate, your brain is able to differentiate when the bladder is actually full and when it's not that full. And it's also able to differentiate whether you're in a good place to go pee or not, and give you that control. In Parkinson's disease, those signals are all affected by the disease. And so it almost goes back to almost an infantile reflex. So meaning that because of the way the disease affects the brain, the basal ganglia, which is the important part of the brain that's affected by Parkinson's disease, then because of that, the brain is almost taken out of the equation again. Okay, and things go back to the way they were when you were a baby. So what happens? It just fills, empties, and repeats. So see that there's a question in the chat. Should I?
You can address them now, or you can wait to the end.
Okay. Okay. So I'll just continue just so I finish this train of thought, not so I don't get everyone confused. So in Parkinson's disease, the bladder just kind of fills, empties, and repeats, fills, empties, and repeats. So it doesn't necessarily fill all the way up as it should, right? So again, it might be a little bit of urine in there, sends that sensation over to your spinal cord, and then it just contracts, right? And then, going the wrong way, just contracts, and then the sphincter relaxes, and then, but then it relaxes very slowly. So as I talked about before, the muscles, when you have Parkinson's, everything's kind of slow. So you run to the bathroom and you feel like you're gonna burst. You get there and nothing happens, or very little happens. Part of that is that there's not much urine in the bladder, right? Because your brain wasn't involved in that discussion about whether it was time to go pee or not. And then secondly, your muscle is slow to open, so it makes it hard to empty efficiently. So in all of this, really the brain's job is to constantly send signals to the bladder that says, relax, relax, do not contract until I tell you that it's okay. That's the short summary of all of this. And in Parkinson's disease, you lose that control. You are still aware of, you can still feel your bladder, you're still aware of that, but you don't have that control over your bladder to say, hold it. You have a harder time with that. Okay. And so if this sounds familiar, then definitely, your neurologist, your primary care doctor can offer some therapies to kind of get you started on things to help with this. And then often they'll refer you to a urologist as well to help. So the goals, the management goals for a urologist who sees Parkinson's patients and manage bladder symptoms, really, if you're having this leaking that I'm talking about, so these sudden urges and then leaks, our goal is to try to improve the continence, try to improve your control. Also try to improve the emptying so that you're not having so much of the urinary hesitancy, which is that time that you're having to sit on the toilet and wait for the urine to start to come out. If you're having urinary tract infections, we're trying to prevent those. We're trying to prevent your kidneys from any damage or any urine refluxing back up towards the kidneys and causing enlargement of the kidney or the ureter, which is the tube that drains the kidney into your bladder. But overall, trying to improve the quality of life. So so the next thing I'll talk about is the evaluation. And so in people that have Parkinson's disease, we generally, the symptoms that they have, we generally we generally label as neurogenic bladder. So neurogenic bladder just means that you've got urinary symptoms that are most likely being caused by your neurologic condition. And that neurogenic bladder can be caused by MS, it can be caused by Parkinson's disease. It can be caused by MSA, it can be caused by a stroke, it can be caused by anything neurologic. And often when you have a neurologic condition, they cause similar symptoms in the bladder because they disrupt that pathway that we just talked about a little bit earlier. So when you come in to see the urologist, what should you expect? Well, the urologist will be wanting to get a little bit about your history. So they want to know when you were diagnosed with Parkinson's. They want to know what therapies you're currently on with your Parkinson's, because some of those medicines can affect the bladder. They want to know, the progression of your Parkinson's disease, the progression of your urinary symptoms, if they've changed. They want to know if you've had a history of an enlarged prostate, if you're a man, or if you're a woman, if you have a pelvic organ prolapse or a dropped bladder or dropped uterus or dropped rectum, which is common in women that have had babies. And they also want to know if you've had procedures done that involve scopes or anything like that going into the urethra, going into the bladder, or anything that, or any kind of history of trauma that could have caused scar tissue. They want to know these other things because those can be treated often surgically or with other procedures and may make you much better and may not be related to your Parkinson's at all. So we want to make sure that we aren't confusing things caused, some urinary symptoms caused by other things that are very treatable with urinary, or blaming them all on the Parkinson's disease. So other things, we check the urine to make sure that there's no urinary tract infection. We make sure that your fluid intake is not too high, because fluids in means fluids out. And I know it's tricky with people living with Parkinson's disease because of the blood pressure issue. Your neurologist is telling you to drink. They might even be telling you to take salt tablets and do other things to help keep your blood pressure up and keep you from having falls. So it can be tricky trying to figure out where the sweet spot is to help manage your symptoms, but at the same time, prevent your blood pressure from dropping. And then some people have just high urine production at night. We call that nocturnal polyurea. It just means, for whatever reason, your kidneys at night just pump out urine at the same rate as it does during the day. And normally at night, your kidneys should slow down. They should really reduce the amount of urine that they're making to allow you to sleep. So the labs that we get is a urine test, again, to make sure there's no infection. And if there's sign of infection, then we might get a culture to see what bacteria is growing. A bladder scan, which is this machine here at the top here, is a way that we just do a little ultrasound in the office that tells us how well your bladder empties. So we have you come into the office, we have you empty your bladder as well as you can. We make sure that you're emptying. If your bladder isn't emptying well, then that's part of the problem, right? That means it's always being topped off, like every few minutes, every few hours. It's just, and that's why you're going to the bathroom so frequently or having difficulty. So we want to make sure that we know that. In some cases, we'll get a urine flow test, which is the Uroflow machine here. And that is just a special test where you pee into that funnel. And for men, you stand up, and for women, we have a little chair that goes over that. And it tells us the trajectory, or not the trajectory, it tells us the flow rate of your urine. So making sure that it's coming out in kind of a bell curve. It should start off slow, and then your flow gets faster, and then it slows down. Often in people with Parkinson's disease, you'll see that it's just slow, 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 and then it comes up, and then it may come down, and then it might do other things that aren't normal. So we want to make sure that that we evaluate that and address that. Other things that you can do are bladder diaries. So this is kind of an example of an electronic bladder diary here, where it keeps track of how much you drank, how much you peed, how many times you leaked, the number of times you peed, to try to give us an idea of what your day looks like and how significant your symptoms are, and also to help us try to pinpoint therapies for you. And then finally, there's Urodynamics, which is a bladder function test. And we generally don't go straight to this. We generally will try some therapies first and see how they work, and then only go to the bladder function test if your symptoms are really severe. We're concerned that there may be some damage or something else going on with the kidneys, or if you're one of those people who we do the bladder scan and your bladder is really not emptying, we might do this test to try to get a better idea of why. So I'll talk a little bit more about that in a few minutes though. So before talking about further testing like urodynamics, I'm going to start with just the general management of Parkinson's disease. So generally, we're starting off by trying to be as conservative as possible. We don't want to do invasive tests. We don't want to start with medications which may potentially interact with medicines that you're already on, or create side effects that may worsen your quality of life, or medications which may just add to the burden, of the medications that you already have to take. So generally, especially if the issue is nighttime, we'll start by recommending having a urinal or bedside commode, or if your mobility is very poor, having these types of these strategies to try to make it easier for you to get to the bathroom. Other things that we will often use is something called timed voiding. So this is a strategy that helps some people. And the way it works is that we recommend scheduling regular trips to the bathroom. So that way you're getting your bladder empty before it decides to empty on its own. So you're just preempting it basically. So you might find that going to the bathroom every hour keeps you from having the incontinence episodes, because you pee before your bladder decides that it's just going to contract on its own and empty. Fluid management, we talked about a little bit before. So that's kind of limiting the intake of irritating bladder foods and drinks. So when we talk about that, we're talking about things like caffeine. So caffeine is a diuretic, meaning that it pulls any fluids from your body and your tissues and dumps it in the bladder pretty quickly. So there are some people who have swelling in their legs and things like that, and they have to take Lasix. That might be something that sounds familiar. They need to take different medications that help to pull those extra fluids and kick them out. Well, caffeine does the same thing. Pulls those fluids, kicks it out, and causes you to have to pee frequently. At least until it's out of your system. And so in addition to that, caffeine also irritates the lining of the bladder. So talked about before, where the bladder contracts without your permission, it makes it even more spastic and makes you have to, gives you more urgency. So you want to try to avoid things like coffee, spicy foods, citrus, carbonated drinks. Those things all irritate the inner lining of the bladder and make it more spastic and cause more urgency. And beer and wine do the same thing. Double voiding is urinating and then waiting a few minutes before you get up and leave the bathroom. And this works best for people who don't empty their bladder as well. So essentially you go to the bathroom, you pee, and then wait a couple of minutes and then see if you can pee again and see if you can get a little bit more out. Sometimes it's the bladder itself is contracting, the sphincter is slow. By the time the sphincter opens, the bladder is done contracting. And so sphincter closes. And then you give it a few minutes and maybe you get another opportunity for the bladder to squeeze again, sphincter open, and get the rest of the urine out. So the benefits of these therapies is really that there's no side effects to them. But I've already kind of talked about commodes. But the other potential issues with some of the things that I just talked about are really that they can be challenging to implement, right? And I'll talk a little bit more about that in just a minute. I do want to just mention pads, diapers, and bedpans. As urologists, we generally don't like to recommend these, right? We're trying to get you out of pads and diapers and trying to eliminate the need for these. But it is a good option for patients who do not wish to undergo procedures or have failed other therapies. They do have a role, unfortunately or fortunately, in trying to improve your quality of life. Their discrete options are available. They come in a range of sizes, and sometimes your insurance pays for it as well. So it's good to check on that. But it's definitely not our first line go-to. It's something to help support us as we continue to work through the therapy options and see if we can find something that works better for you. There are also external catheters. So there are male external catheters. We call them condom catheters. And they go on just as the name suggests. They go on like a condom and then they hook up to a tubing, and they're not really meant for you to just pee into over the course of the day. It's more so to help you with control. So men that have issues with leaking. But it's very important that before using this type of therapy that we check and make sure that you empty your bladder well, because this isn't going to help you empty your bladder. This is more to help with continence or leaking. Okay. And then there are external catheters for women. So this one here hooks up to a machine that wicks away. It's called a PureWick, and it wicks away any urine that leaks out. So the issue for this one is that you really can't be mobile and use this. You've got to be in bed and still in order for this to work. You can't be moving around and you can't really walk around. And then it's also hooked up to a machine that's kind of that's connected to suction. And so you're going to be attached to that machine as well. So unfortunately, these aren't great options, but they are one of the options that are available. And then managing your constipation is really important. So with Parkinson's disease, everything slows down, including the bowels. So when things slow down, the stools get hard, you get obstruction of the bladder. So the hard stool can push on the bladder, can push on the urethra. Pushing on the bladder can cause spasming of the bladder. Pushing on the urethra can cause obstruction and can cause a weak stream or slow to start stream or intermittency, stop and go. So you just want to try your best to avoid that. And you're kind of shooting for this type 4 stool here that looks like a sausage or a snake, smooth and soft, and having one of those bowel movements every day or every other day will help to minimize the urinary symptoms that you're having. Again, a lot of these symptoms are related to Parkinson's disease and how your brain is interacting with your bladder, but these are things that can certainly make it worse. As I talked about before, there are challenges to these therapies. It's nice that that there are few side effects associated with them, but it definitely is challenging to set an alarm and go to the bathroom every hour, especially if you have poor mobility and you need someone to help you. The fluid management, if you've got low blood pressure, your neurologist is telling you to drink more, your urologist is telling you to drink less, that can be challenging. So we often will try to make sure that I'm in contact for my patients, I'm in contact with your neurologist to make sure we're on the same page about your fluid requirements. And then as the person living with Parkinson's disease, it's tough sometimes to feel thirsty and not be able to drink because you're trying to minimize your urgency, your frequent trips to the bathroom, and you're leaking. And then your family member or your caregiver as well has to kind of keep track of how much you're drinking, and if it's too much, if it's too little, and it can all be very difficult and taxing on everyone. So it's great that, again, that these therapies do not have side effects, but please understand that as physicians, and that we understand that they're not easy to implement either, but they are worth trying. Okay, so one last thing I wanted to say too about behavioral therapy is that you can drink too little water. So some people think, oh, just cut out, don't drink hardly anything all day, and I won't go to the bathroom, I won't have accidents. Your kidneys still process fluids, they still will produce urine. They will just produce very concentrated urine. And that concentrated urine is really going to irritate your bladder because it's got a lot of waste in it. It affects the pH and the content of the urine. And so that's going to be irritating. And so you're still going to experience the symptoms. So you're kind of trying to get it just right. You don't want to drink too much. You don't want to drink too little. And then drinking too little also is going to contribute to constipation because then there's not going to be enough water available to stay in the bowels and in the stool and keep it soft. So, so hydration is still very important, that you're getting enough. Okay. So when all of these therapies that I just mentioned are not effective, then we generally will move on to trying things like medications. So I'll go into a little bit of detail, about the medications. So we have two broad categories of medications. They differ mostly on their side effects. So some of you may have heard of medications such as oxybutynin or Detrol or Vesicare. So these are all medicines that basically work on little receptors on the bladder and basically override the bladder muscle itself and try to get the bladder to relax. Okay, so the brain should be doing this. Since the brain isn't able to do it, these medications kind of jump in and try to help with that. Okay, so many of them work well, but they are associated with some side effects. So they can cause a dry mouth because some of those molecules from those medications can affect the glands in your mouth and cause dry mouth. They can slow down the bowels because the job, again, is to slow down your bladder. And so some of those nerves and receptors are also found in your bowels and can cause constipation and slow down the bowels. And then in some patients, some of these medications can cause confusion. And there's some studies that suggest that long-term use of some of these medications could be associated with dementia. And so we're very careful about starting these types of medications on someone over the age of 65. And it's very important that you have these discussions with your doctor before starting these meds, or if you've been on these meds for a long time, remembering to continue to have discussions with your doctor to say, I've been on this for a while. Is it safe for me to continue to stay on this medication for a while? The second category of medication are called beta-3 agonists. They work on a different receptor on the bladder. So for that reason, and again, they do the same thing, they help relax the bladder. But they don't cross-react with the bowels or with the salivary glands in your mouth, so you don't get the dry mouth and the constipation with this. But it can cross-react with some receptors in your blood vessels that cause high blood pressure. And so it's important that your doctor, before prescribing this medication for you, has checked your blood pressure and make sure you have normal blood pressure. Generally, I find that this is actually not an issue for my patients that have Parkinson's, because they're often dealing with the opposite problem. They're often dealing with low blood pressure, and we're trying to keep it up. So this medication generally is not an issue. Bigger downside to this medication is that it's the newest medication, and that it may not be covered by your prescription drug plan, or the copay may be high. So I do use this medication quite a bit in my patients with Parkinson's disease, just because the side effect profile is a little more favorable than the other meds. Okay, so with that said, medications don't work for everyone. Success rates for medications are probably in the 40 to 50% range. And what's tough about medications and success rates is that medications aren't a cure. It doesn't stop all the symptoms that you're experiencing. It just makes it more manageable. And so for some people, more manageable means it's worth taking a pill every day. For some people, more manageable, if they're not significantly better, right, or cured, then to them it's not worth taking a pill every day. So it's really individual in terms of medications. When medications are not effective, then generally this is where I'm in contact with your neurologist, or your neurologist or your primary care doctor is in contact with me, the urologist, and refers you over for further evaluation and to talk about other treatments. And so this is where, when you come to see the urologist, we talk about that bladder function test that I mentioned before. So it's called Urodynamics. And then from there, we have discussions about advanced therapy options, which I'll go into more detail in just a few minutes. So this is a picture of a video urodynamics suite. So this is where we do the bladder function test. And it does, the equipment looks a little bit scary, but trust me, this is just this is mostly stuff that's going to be recording information and taking x-rays. So it's not as bad or as scary as it looks. So we have a little blue chair here on the right. That's where you sit, okay? There's a little cutout, little opening there, because during the test, you're gonna be asked to pee. And while you're peeing, this machine here is gonna measure and tell me what your bladder is doing. And it's also gonna measure and tell me what your sphincter is doing. Is it working properly, or is it slow, as I talked about before? It's also gonna measure and tell me how much fluid is in your bladder and how much fluid your bladder can hold, because I'll be able to pump some water into the bladder. And then this machine back here in the back corner of the room is an x-ray machine. We don't always use it, but sometimes we use it if we're concerned about the bladder and urine urine flowing back up towards the kidneys, or we want to see the sphincter and see the urethra and see how things look. So I'll show you some examples of that just in a few minutes here. So one other thing I wanted to say is that so the urodynamics test is almost like an EKG of the bladder. So the output of the test looks like this, like a little tracing. And the test itself takes about 30 minutes to an hour, just depending on how long it takes to fill up your bladder and how long it takes for you to pee. And so this picture is kind of showing how that all works. There's a little catheter that goes into the bladder. It's a very tiny catheter that has a little sensor in it. And that little sensor tells me the pressure inside of your bladder, so how well your bladder squeezes. And then it also has another little sensor here. This little muscle that goes across here is your sphincter. And this is the sphincter that helps to control your urine, keep you from leaking. So again, that little sensor tells me how that muscle is working. And then the same tiny catheter also allows me to fill your bladder with water. And if I'm taking x-rays, I may add a little contrast there so that I can see your bladder and what that looks like. And there may be another little catheter that goes, if you're a woman, in the vagina, or if you're a man, in the rectum, very tiny sensor that tells me the pressure from that is building in your abdomen, so out here in your belly, because I don't want to know that pressure. I want to know exactly what the bladder does. So the reason I measure this pressure is so that I can subtract that pressure that's being generated by your belly, and so I can get the pure pressure coming from your bladder. And so that's what all these tracings are. So the important one's the green one. The green one is your bladder. And in this example here, this person is doing a good job of storing the urine. This person's bladder is doing a good job of storing the urine. So throughout, I'm testing to make sure that all the pressures are being measured, and that's what all these little spikes are here. So I'm asking you to cough, and when you cough, your belly's generating that pressure. It's not your bladder. So we're testing here, and I'm seeing that it's picking up what it's supposed to pick up, which is only your bladder pressure in this green line. Here's my arrow, okay. And then once we get to the end where your bladder's full and you have about half a liter of fluid in there, which is about normal, then I ask you to pee, and the bladder squeezes. So you see the bladder, so this is just showing me how your bladder is squeezing. This is showing me the flow, which is good. And, or this is showing me how much you peed, and then this is showing me the flow rate. So that all looks good. So it allows me to capture a lot of functional information about your bladder. So let's see an example of a bladder that has Parkinson's and a bladder that does not. So this looks familiar. This is the one we just reviewed. And again, normal as it's filling, and then a nice contraction there and a nice flow rate there. This first one is someone that was an example of someone who has Parkinson's. So again, we're gonna focus on this line here, and you can see that the bladder is doing these little contractions as the bladder is filling, again, without your control, okay? And with each of these, you might have a leak. You may not be capturing in a test, but I'm able to see that. You might see urine leak out with all of these. And then with each of these, often the patient will tell me, oh, I feel like I really have to pee. And then I'll see the bladder start to squeeze. And then I'll say, try to hold it, try to hold it. And often they can't because they don't have the control. And eventually the bladder relaxes again. And then we start putting more water in and it does it again and again. Okay, so that's one of the differences that we may pick up on that test. And then I'd mentioned earlier x-rays. So we don't always get x-rays, but sometimes we'll get x-rays depending on whether we think it's going to be helpful or not, depending on what the symptoms are. So before we start, we'll get a little x-ray so that we can see where the bladder is going to be. So there's no fluid in the bladder, no contrast in the bladder, so we see nothing here. And then as we're filling during the test, then we start to see the shape of the bladder. And this is what we want to see, a nice, healthy, round, oval-shaped bladder. And then once your bladder's full and you're ready to pee, then we ask you to pee, then this is what we like to see. So the bladder is squeezing, so you see it looks more upright and oval this way because it's squeezing like that. And it's pushing the urine out through the urethra. So this is a woman, so there's a short urethra here. And you can see that there's no blockage, everything looks nice and open. So this is a nice x-ray. This is an example of someone that has an abnormal bladder. You might see that the bladder is not smooth, got all these little outpouchings and bumps out here. The person is peeing here and it's coming out, but things don't look as smooth as they did in the other one. And then at some point they have some urine that's going back up towards the kidneys. So we shouldn't be able to see this. That means that some of the urine is going out, some of it is refluxing back up into the ureter, and the ureter is kind of dilated here. It should be thin like that. And then it's going back up in here into the kidneys, and that's also dilated and shouldn't look like that. The good news is that we rarely actually see this in Parkinson's disease. We see it in other neurologic conditions, but I just wanted to give you an example of a normal bladder versus an abnormal one. So after the test, your urologist will review the results with you and make recommendations. So what type of results may you find? Well, you may find a weak or underactive bladder, meaning bladder fills, and then you're ready to pee, but it's just too weak to get all the urine out, or it squeezes for a very short period of time and not long enough to actually get all the urine out. And so with that, we'll see people who retain urine and do not fully empty their bladders. You might also see a bladder that's very spastic, like the one I showed you where there's all those spikes, but still the bladder doesn't get empty. And often those are those involuntary contractions plus a sphincter that's very slow to relax and empty, plus maybe a bladder that's weak as well. So those people may experience leakage of urine, and then they also still don't empty their bladders. You might also see someone who has an overactive bladder. Again, the detrusor is bladder. And you will see involuntary contractions, and you'll see incontinence often in those patients. So let's say that all the therapies that we've talked about are not effective, right? So we've tried medications, we've tried fluid and dietary changes. Now we've done the bladder function test, and it shows that you have involuntary contractions of the bladder. That's what's causing your symptoms. There are a number of therapies that are advanced therapies that are available to help to treat that. And so those therapies include sacral neuromodulation, which I'll start with that. So there are different, at the time I made this slide, Interstim was the only brand, but earlier this year we have another company that also produces this device. I like to think of it as a pacemaker for the bladder. So some people will call it that. So it's produced by the same company that actually produces deep brain stimulators for patients that have for people that have Parkinson's. So it's a similar device in that it helps to modulate the muscle reflexes in the pelvic floor and help reduce those contractions we were seeing in the bladder, so that you have more control and that you're able to store more urine and you have less urinary leakage. It generally involves going to the operating room under sedation, so no general anesthesia, to put in a test device. And then you're tested for 1 week to see whether it helped. And if it helped, then we have you come back a week later and we implant the battery, which is this piece here. The battery come in 2 different varieties. There's one that is rechargeable and MRI compatible. So if you need MRIs, you can have that device. And then there's another device that just stays in, and the battery lasts about 5 years and then has to be changed every 5 years. And that one is not MRI compatible. So success rates are high, and these numbers come, 70 to 85% really come from all comers. So all people that suffer from urinary urgency and leaking related to that. So that may be people that have a neurologic condition. It may not be. This device is FDA approved for people who do not have a neurologic condition. So if you have a neurologic condition, it's considered off-label, which means that it means exactly that. That's just not FDA approved for it. The reason it's not FDA approved for it is that they didn't do the studies in patients that have a neurogenic bladder. Companies didn't. But since then, there are different independent researchers who have done the studies and have shown that it's safe and effective to use in patients that have neurogenic bladder, like MS and Parkinson's. Our group has looked at our experience over the last 10 years, and we find that our success rates are very similar in patients that have Parkinson's, or people living with Parkinson's, and people that are not. Okay. Next is a therapy called percutaneous tibial nerve stimulation, very long term, for a device that helps with urinary urgency and frequency and leaking. It's been FDA approved since 2000. It is off-label for neurogenic bladder again. This treatment is performed in the clinic, so there's no implant. What happens is you come into the clinic, a tiny acupuncture needle is placed in the nerve that goes behind your ankle. I have placed this needle in my own ankle, and you don't feel it at all. It's such a tiny needle. But what it does is help to stimulate this nerve. This nerve goes to the bladder and helps to calm the bladder so that you're not going to the bathroom so frequently. Success rates are about 50%, as I mentioned, not really been studied as much in patients with Parkinson's. Each session is 30 minutes, and it requires 12 weekly sessions. So there is a time commitment, which is what's tough about this, is a time commitment. And then do you have a provider that lives close enough to you to make that trip weekly for 3 months? So given the success rates and the commitment, sometimes it's tough to implement this therapy and get all of the sessions in, because the studies show that you really have to come in for at least 10 sessions to know if it's going to work. You're not going to know after the first one or the first 6. You really need to have at least 10 before you know whether it's going to work for you or not. But what's really great about this therapy is that it's very low risk, in that there is essentially no side effects to this. The good news is that there are new devices that are coming out that will allow you to do this at home. And so that will potentially help many people who are suffering with this condition, who are unable to come in to the office to have it done. And I think it's because it's so low risk, it's worth trying. And then finally, there is Botox. So Botox is FDA approved for neurogenic overactive bladder. So patients with Parkinson's who have these symptoms, it's been FDA approved for a while. There are high success rates. Success rates are in the 70% range, and high patient satisfaction rates. And one injection can last 6 months to a year. I would say on average, it's about 6 to 9 months. And it involves going into the bladder with a little tiny scope and injecting the Botox into the wall of the bladder. And what it does is help get rid of those spasms that I showed you before, those involuntary contractions. And so it's generally done under a local anesthetic in the urologist's office. Patients tolerate it very well. All of these needles and scopes that I talk about are very tiny. But there are potential side effects with this procedure. And so of course, need to have a discussion with your doctor before proceeding with something like this. If you had the bladder function test, it also helps to tell us whether this is something that's going to help you or not. So if your issue is more so that, it's not so much that you're going frequently, but that your bladder doesn't empty well, then in those cases, there's a couple of therapies that can be used. I'll start by talking about what the potential causes are. So it could be a weak bladder, as I discussed before. It could be that slow sphincter that's keeping your bladder from emptying efficiently. And so for either of these, one of the management options is medications. So those medications are medications that we typically use for men that have an enlarged prostate. Just helps to relax that urethra and relax that sphincter muscle so that hopefully during that time when your bladder is actually squeezing, you can get more urine out efficiently. And it can be tried in women as well, which we prescribe it in women all the time to see if it's going to work. And so those medications are things like Flomax. You may be familiar with some of these: tamsulosin, Rapaflo, Uroxetrol, Cardura, Terazosin, or Hytrin. Those are used less frequently, but tamsulosin and Flomax are most commonly used. And it doesn't hurt to try these therapies, but we have to be aware of the potential side effects of using them. So some common side effects would be dizziness and fainting or low blood pressure. It can affect ejaculation in men. It can cause headaches, though we see that rarely. It can cause some congestion, see that rarely as well. Generally, this is a medication that is prescribed for mostly men over the age of 65. So, to minimize the risk of the dizziness and fainting and things like that, we generally recommend taking it before bedtime, and then at night, trying not to get up and go to the bathroom too much, or if you're getting up to go to the bathroom, try not to go too far. Or if you're getting up, remembering to sit up for a few minutes, and make sure that you're not dizzy before you take off. And so generally for this medication, if I have one of my patients that has Parkinson's, I'm checking to see if they kind of have the low blood pressure issue to begin with. And if you do, I really am hesitant to add this medication. I at least have a discussion with the neurologist and say, hey, how's the blood pressure control? Do we think we can try this medication at the lowest dose and just see if it's going to help at all? So it's one of those medications that we have, of course, just like everything else, a discussion before we try. If medications are ineffective, or we have bad side effects, or we decide that it's not worth the risk, then we kind of go back to our other options, which include things like catheters. So this really depends on how significant the urinary retention is. So if it's more so that you're bothered because the stream is weak and it takes a long time to empty the bladder, but it ultimately gets empty, a lot of the time, and the medications don't help, a lot of the time we say, well, we have two options. We can continue with what you're doing now, and you can maybe push on the bladder a little bit, or you can strain a little bit, or we have options of using catheters, which will effectively and efficiently empty your bladder. For folks who can't empty their bladders well, this is really, and medications don't help, this is really the only other option that we have, or the best options that we have. So those would involve catheters, which you may all be familiar with. So this one up top with the green hub here is an intermittent catheter. So it's not one that stays in. It gets passed into the urethra. This is a female bladder, a male bladder, and it drains the urine out, and then you throw it away. And this is a Foley catheter, and this goes into the bladder. The balloon gets inflated once it's inside of the bladder, and it just drains the urine all the time. And the catheter just stays kind of taped to the, secured to the leg, and can stay in for about 4 weeks at a time, and then gets changed every 4 weeks. So the caregiver can be trained to change it. A home health nurse can come and change it, or you may go into your doctor's office, your urologist's office, to change it. And then this is a suprapubic tube. It does the same thing, except for rather than going in through the urethra, it goes in through the lower part of the stomach. So this picture is kind of showing a much larger distance between the bladder and the skin. Your bladder really is right underneath your skin. You have skin, muscle, and then your bladder is right underneath that. So, so a little entrance is created and the catheter is placed directly into the bladder. And the benefit of this is just not having something in the urethra, which can be irritating and it doesn't necessarily reduce the risk of urinary tract infections because you still have something in the bladder. So it's mostly for comfort. This is usually more comfortable than having a catheter down below. And it can be hooked up to a bag or it can be plugged. And when you need to use the bathroom, you unplug it and drain it. And then finally, this is rare, but sometimes, as I mentioned before, sometimes the issue is something that can be treated surgically. So you have an enlarged prostate or a woman whose bladder is dropping. I don't know how I did that, sorry. Or you have a stricture or scar. And so surgery can be used to treat the enlarged prostate or the bladder, if it's dropping, can be lifted through a surgical procedure, again, correction of a stricture or scar tissue in the urethra. And then lastly, I want to talk about nocturia, which is getting up, again, defined as getting up one or more times at night. And generally, this is, again, very common in patients that have Parkinson's disease. And generally what we start with is a bladder diary, though sometimes it can be challenging to get this, but the bladder diary really helps us to determine whether you're just producing too much urine at night, and that's the primary issue, or if there's another issue going on related to sleep or insomnia, restless leg syndrome. We always review your medications to make sure that there isn't anything that's contributing to it. So if you're taking a diuretic, rather than taking it in the morning or taking it right before bedtime, you take it in mid to late afternoon so that it has enough time to capture all that extra fluid that you are retaining in your body and get it out before bedtime. If you take it too early in the morning, then it dumps all that extra fluid, but that fluid has enough time to reaccumulate before you go to bed. That's the idea behind that. And then we do an exam to see if there's leg swelling. So maybe you need to be on a fluid pill because you have leg swelling, or you need to be using compression hose, or you need to be elevating your legs in the evening to try to get all that fluid back up to your heart and your kidneys and your system and pump it out and pee it all out before bedtime. Okay, so the conservative management is generally elevating the legs, compression hose, as I mentioned. In the evening, trying not to drink anything in that last 3 hours before bedtime. Again, in conjunction, that plan would be made in conjunction with your neurologist to make sure that you're getting enough fluid to prevent the low blood pressure. Peeing before bedtime, of course. Avoiding caffeine and alcohol and things that may be irritating in the evening, those last 3 hours. Doing whatever we can to improve your sleep quality. So a lot of people are on their phones, they're on their tablets, they're using electronics right before they go to bed. That affects your sleep, affects your ability to fall asleep. You want to also make sure that there's not noise, make sure that the room is dark, make sure that the bed that you're sleeping in is comfortable and that there aren't other things that are contributing to your difficulty sleeping. If there's pain, we need to do what we can to try to treat that pain. If you have sleep apnea, you snore and should wear a CPAP, trying to get you fitted for one that's comfortable. It's going to help you to sleep better, and it's going to reduce the number of times that you get up at night. If we find that you have an overactive bladder during the day, some of this may be related to that. So if you're going very frequently during the day and having lots of urgency, a lot of the time it's just like that tracing that I showed you of the bladder during the urodynamics test where you're having all those little contractions. Your bladder doesn't just at night decide to stop doing that. It continues to do that 24 hours a day. So overactive bladder medicines can sometimes be helpful with the nighttime symptoms as well. We talked about using a diuretic. Desmopressin or DDAVP is a medicine for people who specifically produce more than 30% of their urine at night. So you'd need to do a bladder diary that shows that for whatever reason, your kidneys don't slow down at night and they just keep pumping like they do all day. And this medication, what it does is synthetic hormones, a hormone that your body produces that reduces the kidney's output during those 6 to 8 hours that you're supposed to be sleeping. And so kids have a really high level of this hormone because they really need to sleep through the night and so that they can grow and mature and all those things. And as we all get older, we make less of this hormone. And so it's not necessarily, this problem of high urine production at night is not necessarily associated with just Parkinson's disease. Anyone can have this. And so the bladder diary is helpful. The medication can be very effective. We usually start at 0.1, which is the lowest dose, and you can go up on that depending on what's effective. With that said, of course, with every medicine, there's potential side effects. So the medication can cause your sodium levels in your blood to drop to dangerous levels. So if you're on this medicine, you have to be monitored very closely, at least at the beginning with weekly blood testing to make sure that it's not affecting your sodium levels or your salt levels in your blood. And so it happens not frequently, 5% of the time, and is associated with adults over 65, and women are more likely to be affected. The reason it happens is because really you're asking your kidneys to hang on to more water while you're asleep, right? Telling them not to pump it out. So it kind of dilutes your blood a little bit over the course of the evening. For most people, it's not enough to cause any problem or any change to your sodium levels, but some people are a little more sensitive to it and it can cause that issue. Otherwise, there are other potential side effects like headache and insomnia, which I rarely see that. But the sodium level is the one that we really keep a close eye on. Okay, so I think I am way over time. As far as the next steps, you generally would recommend seeing a urologist, and if you're having bowel issues, also see a GI doctor for management of the constipation to help discuss further management and kind of determine what's going to try to identify what's going to help your symptoms in particular. Thank you very much. It's my pleasure. I hope it was helpful, and of course, happy to answer any other questions folks may have later on offline as well.